a series that we started last year, sort of taking the time after each of the major society meetings to try to recap major trials and provide a forum for discussion of the trials and their implication in our clinical practice as well as research. Today, we're just going to go ahead and get started. We have three of our distinguished faculty here today to present some of these trials. We have first Yuan Liu, followed by Tariq Ahmad, and then followed by Yusuf Ahmad. So with that, I don't think any of these faculty need much introduction to all of us here. We'll go ahead and get started. And perhaps this time we have three, not four speakers, but maybe we'll also save questions and answers till the end of the session so that we can have time for a more robust discussion. All right, with that said, we'll get started, and it's a pleasure to present Yuan Liu, who's someone that I work very closely with. Yuan.
Thank you, Oyeri. Let me share my screen. Can you see my slides okay?
Yes.
Okay. Good morning, everyone. Thank you for inviting me. Today, I'm going to give an overview of the China Rural Hypertension Control Project. This is not a project I'm involved, but I'm take a very close look in the AHA section. It is an RCT of a village doctor-led intervention on blood pressure control, presented by Dr. Jiang He from Tulane University as a late-breaking session in the AHA. The trial sponsor is the Ministry of Science and Technology in China. First, just a little bit background. Hypertension is the #1 leading risk factors for cardiovascular disease in the world. This map shows you the age-adjusted mortality, cardiovascular mortality attributable to systolic blood pressure in the world. We can see that hypertension is really a global pandemic. In this map, the yellow and red color indicate higher burden of hypertension contributing to cardiovascular disease. In fact, 75% of the cardiovascular disease burden attributable to hypertension happen in low and middle income countries. The randomized control trial has provided strong evidence to show the association between blood pressure reduction and prevention of cardiovascular events. This is from a paper published recently in Lancet. The author conducted a meta-analysis of 51 RCTs, including more than 358,000 participants. And on the figure on the left-hand side, it shows the rate of major cardiovascular events associated with 5 millimeter per mercury reduction in SBP. And different colors of lines shows by different age group. As you can see here, the hazard ratio for 5 millimeter per mercury reduction of SBP is associated with less than 1 hazard ratio significantly for major cardiovascular events. On average, 5 millimeter per mercury reduction of SBP reduce the risk of a major CV event by 10%. So this is a take-home message from this paper. Even a small reduction of blood pressure is associated with a substantial amount of risk reduction in CVD. In China, the prevalence of hypertension is pretty high. However, the control rate of blood pressure is pretty low. Is 27.8% of the adult, which is equivalent to 292 million adults in China have hypertension. This is based on the blood pressure greater than 140/90. In the national survey, it shows less than 10% of the hypertensive patients have blood pressure control. Again, this is based on the old blood pressure control target based on blood pressure over 140/90. In the rural area, the situation is even worse. The control rate is only 5.5%. Now in China, we have this called the village doctor. Village doctor is traditional, we call it barefoot doctors. They have provide basic primary care in rural China. With appropriate training, this village doctor could play an important role in hypertension control in rural China. So this is village doctor similar to community health worker in the US. They have a strong tie with the local residents, and they also have some basic knowledge in terms of primary care prevention of chronic disease such as hypertension. This trial is a cluster randomized control trial of 326 villages. The study have two aims. First, they want to test the effectiveness of a village doctor led multifaceted intervention compared to usual care on blood pressure control over 18 months among rural residents with hypertension in China. Secondly, they want to test the feasibility of implementing a more stringent blood pressure treatment goal, which is based on the 2017 AHA and ACC guideline to reduce blood pressure less than 130 over 80 than the current China hypertension guideline based on the blood pressure less than 140 over 90. This is the graph of the study enrollment and randomized. In total, 326 villages selected from 3 provinces in China were included in the study. Half of these villages were randomized to the intervention arm, and half of them randomized to the usual care control arm. All of these participants need to complete follow-up visits, including 18 months. So finally, there are about 174,000 participants included in the data analysis in the intervention arm, and 165,000 participated in the control arm. The study participants, including adult age greater than 40 years old, either with an untreated blood pressure over 140 over 90, or a treated blood pressure over 130 over 80. They also included patients with a history of cardiovascular disease, diabetes, or CKD, and blood pressure over 130 over 80 included in the trial. Finally, all of these patients required to be enrolled in the China New Rural Cooperative Medical Scheme. This is insurance cover 99% of the rural residents and provide basic healthcare services in rural area in China. The intervention is a simple step care protocol for hypertension treatment. They adapted from the 2017 ACC and AHA hypertension clinical guideline, and it was implemented to achieve a target of SBP less than 130 and DBP less than 80. To achieve this intervention, the authors used several implementation strategies. These include the village doctor in the intervention group, were trained on standardized blood pressure measurements, protocol-based hypertensive treatment, and health coaching. So, additionally, the village doctor can initiate and titrate antihypertensive medication and conduct health coaching on lifestyle modification and medication adherence, and also conduct follow-up visit with the patient on a monthly basis. Third, the village doctor was supervised by the primary care physician, either from the township hospital and the hypertension specialist at the city or county hospital. Finally, the patient in the intervention village also received discounted or free antihypertensive medication, home blood pressure monitoring, and health coaching. This is the baseline characteristic of the study participant. You can see the characteristic of participants are quite similar in the intervention group and the control group. The mean age is about 62 or 63, and 60% of the participants are women. And at the bottom, you can see the mean blood pressure level at baseline. Is systolic blood pressure is 157, and diastolic blood pressure is 88 in the intervention group at baseline. In the control group, the blood pressure is 155 over 87 at baseline. The study primary outcome is the proportion of patients with controlled blood pressure in the follow-up. And the primary outcome is based on the blood pressure less than 130/80 using the recent AHA and ACC guidelines. At the end of 18 months follow-up, 57% of the participants in the intervention group and 19 or 20% of the participants in the control group have achieved the control goal. What I want to highlight, this is a large, big difference between the intervention and control group, 37% difference between the two groups. The secondary outcome is the blood pressure control rate based on the older blood pressure control target, 140/90. At the end of 18 months, 77% of participants in the intervention group and 44% of the participants in the control group have achieved the control target. Again, there's a large, big difference between the two groups, 33% difference, net difference between the two groups. The author also looked at several secondary outcomes, including the mean systolic and diastolic blood pressure. So in the intervention group, the mean systolic blood pressure reduced from 157 at baseline to 143 at the end of 18 months follow-up. And for the control group, it reduced from 155 at the baseline to 130 at the 18 months of follow-up. The reduction in the intervention group is very impressive, is 26.3 millimeter per mercury reduction in systolic blood pressure. Similarly, the reduction in diastolic blood pressure also very impressive. In the intervention group, it reduced from 87.9 at baseline to 79.5 at the end of 18 months of follow-up. So the reduction is about 15 millimeter per mercury in the intervention group. This is even larger than what we have seen from the Kaiser program in the US. Again, they also conduct several subgroup analysis to look at whether the results are consistent across subgroups. They see pretty consistent result. You can see for all subgroups, the group difference is greater than 35%. So it's very consistent result for different subgroups. Showing this intervention led by the village doctor can really reduce the blood pressure effectiveness. And based on this result, the authors make two conclusions. First, the village doctor-led multifaceted intervention significantly improved blood pressure control among rural residents in China. They also conclude that this intervention is a feasible effectiveness and substantial implementation strategy could be scaled up to rural China and other low resource settings for hypertension control, and even considering to use it for reduced CVD and all-cause mortality. There are several points I want to discuss with you. First, I see the importance of leveraging non-MD providers in hypertension control and CVD prevention, not only in China, but also in the world, in the US. In China, they use village doctor, but in the US, we have community health workers, we have pharmacists, we have care coordinator, nurses. There are evidence from different trials, including the barbershop study and many other clinical trials to show community health workers and pharmacists-led intervention can really effectively reduce the blood pressure in residents in the US. Secondly, this study also highlights the importance of multifaceted strategy to address barriers to implementation. Sometimes the intent of the intervention is always good, but sometimes it will lead to unintended consequences if it's not implemented appropriately. In this study, the author adopted multifaceted strategy, including home blood pressure monitoring, health coaching, and regularly follow up with the patient and use the village doctor to improve medication adherence in the patient, etc. So really thinking about a strategy to improve the implementation is an important aspect to the success of this study. And third, this study shows the potential for adaptation in low resource setting in the US. They frame this as a successful model to be scaled up in low and middle income country, but also in high income country, there are low resource setting. So considering non-MD provider as a high touch approach could be potentially adapted in the US. And finally, I want to highlight the role of digital technology to augment the intervention. In the US, we have, say, Bluetooth blood pressure monitoring. We also have different digital apps, cuffless blood pressure measurement, Fitbits for measuring the physical activity of the patient, and different apps to improve communication between doctors and patients. So we can consider leveraging the digital technology as a high-tech approach and combine with community health workers, pharmacists, nurses as a high-touch approach to really as a combined intervention to eradicate hypertension and improve CVD prevention. That's all my point. Thank you for listening, and I'm welcome all the question and comment at the end of this presentation.
Thank you very much, Yuan. We'll just move on now to Tarek, and we'll take questions at the end of the talks. Thank you.
Thank you, Oyi. Can everyone see my slides? Just want to make sure.
No.
No? Let me see.
Yes, no.
Perfect. Well, thank you for inviting me. This is a great honor. This was our study based out of Yale that we presented at AHA as a late breaker. So I'd love for everyone's feedback because in some ways it's a product of the Yale system, and it's essentially the primer for future studies that we're doing across our system. So thank you for allowing me to present this. These are my co-authors. This is the funding information for the study and disclosures. So for as long as I've been interested in heart failure, goes back all the way to residency, we've had this assumption that accurate prognostication of patients with heart failure would enhance use of interventions, and that would lead to reduced adverse outcomes. Numerous risk prediction models have been derived from cohort studies, randomized trials. This ranges from simple ones to machine learning, but they're essentially never used clinically. The impact of risk prediction in heart failure on clinical decision-making and outcomes has never been tested in a randomized controlled fashion. Furthermore, the guidelines don't anchor management recommendations and accurate quantification of patient risk. So essentially, they assume that the individual clinician will estimate risk and make decisions on the basis of their estimation. So the study hypothesis for REVEAL-HF was the following. We said providing clinicians caring for a hospitalized heart failure patient information about their predicted risk of one-year mortality would translate into improved treatment decision-making, and this would lead to a reduction in rates of rehospitalization or death. This is a study design. It was entirely pragmatic, done through the electronic health record. If a patient was hospitalized with acute heart failure, as we defined as NT-proBNP levels greater than 500, and they got IV diuretics within 24 hours, they were automatically enrolled in our trial and randomized to their clinician getting an alert while they were entering orders. So when they were engaged with patient care versus usual care, which is no alert. And what the alerts showed was one-year mortality risk estimation with visual, and then there was a link to the study site. Also, all the data was collected through the EHR completely electronically. So there was no kind of case report forms or research coordinators going and collecting this information. And our primary outcome was all-cause mortality or heart failure rehospitalization composite. So this is what the clinicians saw. Some of you might have already seen this when you were out on the clinical wards. It had three key components. First of all, you got a calculated numeric risk of all-cause mortality at 1 year for the patient. Then you had a visual that showed you where in the bucket of risk the patient fell. These buckets were created with input from heart failure clinicians as to what they thought was very low, low, medium, high, and very high risk. And finally, what I thought was a very interesting aspect of the study was we asked the clinicians what they thought about this risk assessment. So we asked them to get engaged in kind of this thinking about risk. Did they think it was appropriate? Was it too high? Was it too low? Or were they not sure? This is the risk score performance, and essentially what we did was we looked at historic data from the Yale New Haven Health System for patients who met criteria for reveal, and we created we essentially calculated the risk score based on this historic data with derivation and a validation cohort. It had good discrimination when you compare it to other risk scores that are out there with the C statistic of 0.742 and good calibration. The risk variables that went into the risk model are shown down here below. There have been several publications that have shown most of these variables to have prognostic implications in heart failure. Just as an aside, while we were developing this, it was very important for us to have an algorithm that does not impact the computing of the electronic health record, because if it slowed down Epic across the system, we would not have been able to do the study. So that's something to keep in mind as people are coming up with algorithms to run across healthcare systems. We estimated the composite outcome would occur in about 30% of the patients based on historic data. We felt that about 25% reduction would be clinically meaningful. This left us with a population of 3,124 patients needed to test our primary hypothesis. As I previously mentioned, this is an embedded heart EHR-based pragmatic trial across our health system. We only did this at teaching hospitals, and I can get into that later if anyone has questions about that. But it was done at 4 hospitals, started at the end of 2019. And as you can see, within a little bit more than a year, we were able to enroll the 3,124 patients, which, as far as I can tell, was probably the fastest enrolling acute heart failure trial ever. The C statistic for our clinical trial data set was essentially the same as our validation data set with 0.738. These are the baseline characteristics of our patients. I mean, if you look at how they compared to acute heart failure populations across the country, it's pretty similar. We had 50% female, about a fifth were Black patients, 10% Hispanic, and about a third had heart failure with reduced ejection fraction, high burden of comorbid conditions, and of note, a pretty significant number of patients tested positive for COVID. So what do the studies show? These are the primary clinical endpoints, and as you can see, the informational alert made no difference in the composite outcome. Almost 39% of patients met the primary endpoint, which was much higher than we had predicted, and was not significantly different. If you look at the other components of the primary endpoint and mortality, there was absolutely no difference. 27% 1-year mortality in this patient population, 20% 30-day readmission. That's incredibly high and at par with what we see with hospitalized heart failure patients who are incredibly high risk patient population. We looked at pre-specified subgroups and how they might impact the interact with the alert and the outcome. There was no indication that age, sex, race, creatinine, EF, NT-proBNP levels, where the patient was admitted, or even baseline risk impacted the alert's effect on the outcome whatsoever. In terms of some components of clinical decision making, there were several others that we're looking at, but I wanted to show these two. So there is quite a lot of discussion about getting patients with heart failure with reduced ejection fraction on guideline-directed medical therapy. These were the discharge doses. Percentage of people discharged on guideline-directed medical therapy. As you can see, absolutely no difference between the alert and a no alert arm. And just if looking at this, these numbers are actually quite good compared to national data. About 94% patients on beta blockers, 72 on ARB-ARNI, almost 40% on MRA, and very high doses of SGLT2. And so we're in terms of getting people on GDMT compared to national trends, we were doing pretty well, but there was no difference according to alert arm versus not. You might expect that patients in the higher risk categories would have higher palliative care referrals. Numerically, they were slightly higher, but given the low numbers, these did not meet significance as well. Now, finally, this is quite an interesting aspect of the study where we looked at interaction between what the clinicians felt, the predicted outcomes, and the observed outcomes. And what you can see here is in the high risk and very high risk groups, there appeared to be a signal that clinicians were able to calibrate risk within these predicted risk categories quite well. So clinicians were able to stay within the high risk predicted group and very high risk group that this patient is maybe the predicted risk is too high or too low. And they were quite right about it. So this has implications in terms of how clinicians interact with algorithms in the future and currently. So several limitations of our study need to be considered. The model performance was equivalent in discrimination. So discrimination is whether you can tell between high and low risk. It was inferior in calibration. So the observed risk was observed outcomes were much higher than, or were higher than our predicted risk. We had, we had done this study to address a hypothesis. So that's why we used internal cardiology, internal data at Yale to maximize internal validity, so we can address the study hypothesis. But we suspect that the calibration was lower due to excess mortality seen during COVID-19. And there have been publications on COVID's impact on heart failure recently that lend credence to this hypothesis. Are the findings generalizable? We think they are, because there were patients who were automatically recruited from Yale New Haven that for lots of reasons, the patient cohort seen at Yale New Haven Hospital is almost identical to the demographics of the US population in terms of heart failure. So we've looked at this and comparing it to CHAMP registry and other registries, and it's very, very similar in terms of the makeup in terms of age, ejection fraction, and race and ethnicity. Finally, it could just be that clinicians don't pay attention to EHR-based alerts. I mean, there's something that many of you clinicians will be familiar with, which is called alert fatigue. You just want to X out of it. You really want to just get moving with what you're doing. That may be responsible for this. There's something known as algorithm bias, where clinicians will trust their gut instinct versus what an algorithm can tell them, even if they know for a fact that the algorithm is better. So in conclusion, we found that mortality estimates provided to clinicians during standard workflow did not lead to significant reductions in rehospitalization or mortality amongst patients hospitalized for heart failure. Mortality estimates did not significantly influence use of medical therapies, ICD implantations, transplant VAD, or referrals to palliative care. And we think that the study shows that bedside clinicians may require more prescriptive decision support, as just the hypothesis that accurate prognostication alone will lead to better decision-making may not be correct. And this comes at the heels of other studies in heart failure where, for example, the ESCAPE trial that had, PA catheter-guided treatments, or the guided study that looked at NT-proBNP as a way to prompt clinicians to do the right thing, were both negative studies. So I think what we're starting to learn in heart failure is just if you can measure something that tells you, prognostic information about the patient, and you leave it to the individual clinician to decide what to do, you may end up not making a positive impact. You need to be a lot more prescriptive in telling clinicians what you need to do with this information. So with that, thank you, and I look forward to hearing from colleagues about kind of input and feedback and what we can do in the future with this kind of clinical research pragmatic trial setup that we've put together here at Yale. Thank you.
Tarek, thank you so much for that. And I just have to say it was really sort of a moment of pride, seeing you up there presenting this as a late-breaking clinical trial. So congratulations to you and to the rest of the team working on this. With that, we'll move on to Dr. Yusuf Ahmad, and afterwards take questions. Thank you.
Thanks very much. Can everyone see my screen?
Yes.
Great. Okay.
Yes, we can.
It's a pleasure to be able to speak with you all. My name is Yusuf. I joined faculty at the beginning of October. I'm going to discuss the AVATAR trial, which I think you all know is a randomized trial of asymptomatic severe aortic stenosis randomized to surgical aortic valve replacement or conservative care, presented at AHA with a simultaneous publication in Circulation. We'll go over the trial and the main results, maybe some caveats to interpretation. I'll try and put the results into context with the recovery trial, which was published in the New England Journal of Medicine last year, and maybe some implications for both our clinical practice and clinical guidelines and future research endeavors. As we all know, the bedrock for how we manage patients with aortic stenosis has generally been their symptomatic status. When they have symptoms we feel are attributable to the AS, we refer them for intervention on the valve. And if patients are asymptomatic, we may employ watchful waiting, longitudinal follow-up of the echo, and clinic review to assess the symptomatic status. I think this figure is probably the most commonly shown figure in any talk on aortic stenosis, showing that the onset of symptoms has a dismal prognosis. But of course, that this was a post-mortem based study where 100% of the participants were dead. But in terms of the guidelines, we know that for severe symptomatic aortic stenosis, it's very clear cut. But the guidelines actually do give us some guidance for asymptomatic patients as well. And this is relevant for the questions that the trials are aiming to answer, because patients with an ejection fraction of less than 50% currently have a class 1 guideline recommendation for aortic valve intervention. That could be surgery or transcatheter. But it's the other patients where it gets a little bit more complicated. If you do an exercise test and you either provoke symptoms, demonstrate reduced exercise capacity, or a drop in systolic blood pressure, then that gives you a 2A indication. You could argue then that they're not asymptomatic because we're prompting symptoms. And then there are a handful of markers, either biomarkers with BMP or echo markers with very severe AS with peak velocities greater than 5 meters per second, or rapid disease progression, which is classified as increase in that peak velocity of more than 0.3 meters per second. Then that can give you a 2A indication for surgery. It's important to note that the details of this guideline for all of these asymptomatic patients state that they should be at low surgical risk. And I think that's important because we're talking about a risk-benefit assessment for each patient where we believe the risk of the intervention doesn't outweigh the potential benefit. And that may not be the case for patients at higher risk. The European guidelines are really very, very similar. The only difference really is the European guidelines, the fall in systolic blood pressure needs to be 20, and in the American guidelines it's 10, but in general, very, very consistent. So EF less than 50 is a class 1 indication, and the other markers you can look for in other patients for class 2. So the AVATAR trial is aiming to answer this question, which is what do we do with patients who have severe aortic stenosis, asymptomatic, and normal left ventricular function? Up until very recently, we had no trial data in this field, and all management decisions were really based on either expert consensus or observational data. This was a multi-center international trials, investigator-initiated, conducted in Europe. And their primary hypothesis was that early surgery would reduce the composite endpoint. Their composite endpoint was all-cause death, acute myocardial infarction, stroke, or unplanned heart failure hospitalization. As I said, European trial, 157 participants, so not huge numbers, similar to the recovery trial. The exclusion criteria would really be those patients that already have clear indications for surgery, so symptoms, reduced ejection fraction, very severe aortic stenosis, or patients with significant concomitant cardiac or extracardiac disease. I think something that's worth spending a moment on is that exercise testing was mandated as part of this trial. That wasn't the case, in fact, in recovery. And so all patients had an exercise test, and if you either provoked symptoms or they couldn't exercise sufficiently, evidence of ischemia, or a drop in systolic blood pressure, those patients were all precluded from entering the trial. So patients really had to be proven objectively to be asymptomatic to get randomized. Patients who were randomized to surgery, the aim was that they had surgery within 8 weeks. Patients randomized to conservative therapy ought to be referred to surgery if they developed any of these clear indications, such as a drop in EF or symptoms. The primary analysis was intention to treat, although there was an additional as treated analysis for patients who actually underwent surgery, as opposed to just randomized. The average age was 67, and they did appear to be low-risk patients. The STS predicted risk of mortality is 1.7%. Predominantly degenerative AS, with a smaller proportion having bicuspid or rheumatic. This is a little bit different to the recovery trial, where most of the patients were bicuspid. The median follow-up was 32 months, about half and half mechanical versus bioprosthetic valves in the surgery arm, very similar to recovery. In the patients randomized to early surgery, the median time from randomization to having the operation was 55 days. The operative mortality was low at 1.4%, which is what we would want to see in a trial of low-risk patients. In the initial conservative therapy group, ultimately 25 patients had surgery. Their median time from randomization to surgery is 400 days, or just over a year. And a combination of reasons, the most commonly being development of symptoms, one patient with a drop in EF, and 20% of patients for a combination of factors. This is the Kaplan-Meier for the primary endpoint. And just to recap, that primary endpoint was the composite of all-cause death, acute myocardial infarction, stroke, and unplanned heart failure hospitalization. So the red line is the conservative therapy group. Their event rate was 34.7%. The blue line was the early surgery group. Their event rate was 15.2%. So the hazard ratio of 0.46. So early surgery gave a greater than 50% reduction in the primary composite endpoint, which was statistically significant. The upper limit of the 95% confidence interval was 0.9, and the p-value was 0.02. You can see here mortality, which is on the left-hand side of the screen. There's a difference between the two lines. It doesn't reach statistical significance. The p-value is 0.16. Heart failure hospitalization, again, narrowly misses significance, but everything numerically is in favor of early surgery. Just to show you some of the numbers, so the all-cause death rate was 4% in early surgery versus 13% in conservative therapy, and you see the hazard ratio 0.56. But because the upper bound of the 95% confidence interval is 1.27, not statistically significant. Interestingly, no difference in cardiovascular death between the two groups, identical rates of cardiovascular death. So they concluded that patients randomized to early surgery had a lower incidence of the composite primary endpoint. And as I said, these are truly asymptomatic patients. Every single patient had a mandated exercise test before enrollment. And if the exercise test was abnormal, you were precluded from being randomized. Some caveats that we should probably discuss. One is that there's no difference in cardiovascular mortality between the two groups at all. Now, this could partially speak to difficulty in adjudicating causes of death, but it could also maybe reflect the chance finding of the all-cause mortality. This is potentially confounded by COVID. If you look in the supplementary appendix, in the conservative therapy arm, 3 patients died from COVID pneumonia. No patients in the surgery arm had a COVID-related death. I don't think anyone would say that aortic valve replacement is protective against COVID-19. I mean, you could argue that patients without severe aortic stenosis could better survive non-cardiac illnesses. But this, underlines that when you're dealing with small numbers and few events, the results can be fragile. And just a handful of events that would shift from one group to the other would change the statistical significance. I think surgery versus no surgery trials are very difficult to randomize to. Patients might not want to be willing to be randomized to something as dramatic as open heart surgery. And this is maybe magnified in asymptomatic patients. As I said, the recovery trial is another randomized trial that we have. Similar numbers published in the New England Journal of Medicine at the beginning of 2020, run out of Korea. Their primary endpoint was a composite of cardiovascular death or operative death. They did not have systematic exercise testing prior to enrollment, and they mandated very severe aortic stenosis. These patients are getting close to those which already have guideline indications for surgery. So they required a peak velocity of more than 4.5 meters per second. Over half of those patients had bicuspid AS, zero operative mortality. Again, both trials had very low or zero operative mortality, which I think is important for low-risk patients, asymptomatic, that you're putting forward for surgery. You can see here their composite endpoint was significantly reduced with surgery, and all-cause mortality was also significantly reduced with surgery. And I just wanted to put the results for all-cause mortality next to each other. The recovery trial on top, you can see that result is statistically significant, but I would argue that both trials really show consistent results. If you look at the point estimates and the confidence intervals, they really agree with each other. And if you synthesize the results of these two, the heterogeneity would be very low or absent. So it seems there's a consistent signal here. So if we look at the totality of the data, we have two randomized trials demonstrating clinical benefit. I would say that there's evidence of a benefit of reduction of all-cause mortality for the patients looking at both of the trials together. We should acknowledge the number of patients is small, the number of events is small, but this is not atypical for surgical randomized trial data. We should acknowledge that this doesn't apply to higher risk patients, which is important with patients who are, if you're putting patients forward for an intervention and they're asymptomatic, you want to be sure that the risk of the intervention isn't going to outweigh the anticipated benefit. And these results apply to low-risk patients. And these results don't apply to transcatheter aortic valve intervention. We don't have that data yet. We currently have 2A guidelines for patients with asymptomatic severe AS and normal EF who meet certain criteria. I would argue that maybe we need a class 1 recommendation on the basis of these two trials and the mortality findings. Implications for clinical practice. It's hard to send asymptomatic patients for cardiac surgery. I think a lot of clinicians aren't comfortable referring patients who are asymptomatic. Maybe a lot of patients wouldn't be comfortable undergoing surgery. We might want to adopt approaches similar to they used in Avatar, which is mandated exercise testing to prove an asymptomatic patient. And, when we're discussing asymptomatic patients, you want the morbidity and the mortality of the intervention to be low. So there may be a role for transcatheter approaches where you would hope for less operative morbidity and mortality, earlier recovery, but we have to evaluate that in prospective randomized trials. There are a handful of those trials ongoing, some of which are listed here. And if you look at the numbers, they're going to be much bigger than the surgical data that we have. So we'll learn more about the potential role for transcatheter intervention, either in asymptomatic severe AS, moderate AS, or patients with moderate AS and heart failure syndromes. So I'll stop there to leave time for discussion. And thank you all very, very much for your attention and for inviting me.
Thank you very much, Yusuf, and a very warm welcome to the faculty and a warm welcome to the Grand Round stage. And I thank you all really for bringing this all in on time so that we can really open the floor to questions. We've heard some really different, but I think important talks from the three presenters. So I'll open up the floor for questions. You can use the hand raise function. You can type a question in the chat. I see a comment here from John Forrest, sort of highlighting what you mentioned earlier, which is that the early death for low-risk TAVR studies is 1.6% versus the 4% and 7% that are noted, in the surgical studies that you highlighted. All right, so why don't we go to you and then to Arya next?
Yeah, so just two quick things to follow up on Yusuf's. One, the asymptomatic TAVR studies they're almost fully enrolled now. We have had a challenge, as we have historically, enrolling in these trials at Yale. But since I have this opportunity, I think there are literally 20 spots left nationally. So if you have a patient who has asymptomatic severe aortic stenosis, again, these studies are requiring patients to undergo a treadmill beforehand. I will also note, the data is pretty convincing now that, that Bromwald's initial curve, which was based on like 60 patients, is probably not accurate when it's redone. And when you trace out patients who have severe asymptomatic aortic stenosis, there's a large number of trials, this being one of them, which is showing that early intervention is probably going to be beneficial. I'll simply add that actually the next step, which is being looked at, is taking patients who have moderate aortic stenosis and anything, a high calcium score, atrial fibrillation, an elevated BNP, et cetera, and randomizing those patients to have their valve replaced. The more we learn about aortic stenosis, the more we realize the impact that it has on the myocardium and on outcomes in these patients. And so sort of more to come along those lines. Thank you.
Excellent. Thank you so much, John. And certainly, I think I have one patient to send to you, so I'll get on it to claim one of those spots. Arya?
Yeah, first of all, congratulations to all three speakers. This was phenomenal. I mean, they kind of summarized everything beautifully. I want to also, my question is for Tariq, which actually, first of all, congratulations for enrolling so many patients so fast. I mean, this is, it speaks to your power. I actually noticed, if I'm wrong, not wrong, that the GDMT was different between high-risk patients, although it didn't meet the significance threshold. And I was wondering actually that this, maybe you have to enroll very high-risk patient and see the difference, and then give alert to, only when you have a very high-risk, very, very high-risk patient, and that time you may have a less fatigue from the practitioners. So I don't know what your thoughts are on that.
Arya, thank you so much for kind words, and just so everyone knows, I actually was an AHA fellow as a medical student with Arya many years ago. So it's really nice to come full circle. But Arya, so the difference, numeric difference, was in referral to palliative care, not GDMT. And the numbers were so low that it did not meet significance. But I think you're right. So if it depends on what you mean by high risk. So is 10% is 40% risk of 1-year mortality high risk or not? I mean, I would argue that is pretty high, and we should still be focusing on this patient population because it's still very high. But I agree that if we had focused on the very, very high risk patients who have incredibly high risk of 1-year mortality, the results may have been different. And that's a future study that we should do. And we should be much more prescriptive in saying, okay, your patient has a very high risk of death at 1 year. You should consider, referring to advanced heart failure, referring to palliative care and things like that. We know from the literature that these referrals are really rare and should be far more frequent. The second thing is that we have another study that is actually looking at more prescriptive alerts, and hopefully that will be it will be presented soon. So I can't tell you the results, but I think that that's kind of where where we're going, where we need to be able to use the electronic health record to augment clinician behavior rather than burn clinicians out. And this needs to be done in a very thoughtful manner. So we need to get rid of alerts that are not doing anything. And we need to really study this in the same way that you would study any other intervention.
Thank you.
Excellent. Thank you, Tarek. I'll go to Jeff Bender, and then we have a couple of comments in the chat.
Tarek, also congrats, phenomenal accumulation of patients and data. I have a question. This might be a kind interpretation, but do you think part of the lack of impact of alert in your study could be because you only included teaching hospitals? The kindness of that is that GDMT use was quite high throughout in both groups, and maybe that wouldn't be the same out in the community somewhere, and that alerts may trigger better therapeutic management.
So Jeff, that's a very insightful comment. And for this study to have even been possible, we needed to have the IRB waive the need for patient consent, right? Because this is a minimal risk study. And right before the study was launched, Perry Wilson published the results of his AKI alert study across the health system. And there was a signal that alerting clinicians about kidney injury increased mortality at the non-teaching hospitals. So as a result of that, the IRB felt that that we couldn't. I mean, I have thoughts about this, but obviously, as a result of those findings, they only wanted to do the study at teaching hospitals. I completely agree with you that moving forward, we should, and to make it more real world, like we should be doing this at non-teaching hospitals as well. But your point is extremely well taken.
Good. Thanks.
Thank you. I'll take privilege here to ask a question. Ewan, this is for you. I mean, the study you presented is really, obviously right up my alley in terms of, large-scale implementation of blood pressure control, as well as cardiovascular risk reduction. A couple of questions. One is, when you think about kind of the expansion of this village doctor program more widely in China, what is the support? Where is the support going to come for that kind of large scale intervention? And do you think with the way that this study was set up, that there is any way of looking at, more hard outcomes a little bit down the line beyond changes in blood pressure?
Thank you, Oyeri. This is a great question. I think the first question you raised about the support of village doctor, there has been a long debate about that. Like village doctor, they have the salary is not so good, and then many people they get training and they leave the village and come to the city to become a doctor over there. So I think the support is really coming from the government. Like in terms of human resources, the village doctor was supervised by primary care physicians from the township hospital, which is one level up than the village. And then there's also from the city and county hospital providing regular training to the village doctor. And also I know there's some regulation to trying to improve the compensation and salary for village doctor, keep them in the village. Also, the patient there receive support. Here in this study, because of the insurance in the rural China is called the China New Rural Cooperative Medical Scheme. They provide discounted free medication for antihypertensive medication and also home blood pressure monitoring to the patient. So there's really no financial burden on the patient side. I think this is one important reason the compliance or the adherence of the intervention for the patient is high in this study. And then in terms of expanding this intervention beyond hypertension control, I see there's high potential there. This pipeline can also apply to other chronic disease conditions such as diabetes, dyslipidemia, using the same approach, leveraging village doctor or in the US like community health workers, pharmacists, non-MD providers to provide this service. And if the study have longer term follow-up, they could also look at cardiovascular event to see cardiovascular event reduction there. So there's a great potential. And I think in the US, especially in no resource setting, maybe in the low income community or minority community, we can also think about that, like leveraging community health workers, pharmacists. We already have lots of evidence from the barbershop study and other intervention study to support that. And then we can use, as I mentioned, to use the digital technology, including the decision support tool that Terry mentioned, to, like embed it into that, into the implementation package to really augment the intervention.
Yeah. Ewan, you have a question here from Dr. Velasquez asking if you can speak to how the individuals in the villages that were randomized were informed about the study ongoing. Like, how did they communicate the study to the individuals that were randomized?
This is a great question. Actually, this study has not published yet, so I couldn't see more detail beyond the presentation Dr. He provided in the AHA. But I can speak using one of the examples, the China Peace study I have been involved in the last few years. In that study, we conducted a health screening for about more than 5 million, around 5 million participants in all 31 provinces in China. And each of these local setting, like either village or county, usually there's a community leader in the village or in the setting. They have been a leading role to communicate the study to the participant, and then they're also using like newspapers, television, and posting all these different means to inform the study participant. But I think in rural China, it's maybe more important to like using the local leader as a connection person to communicate between the researcher and the village residents.
Excellent.
We need to look further for the publication from this study to know more about that.
Excellent. Thank you so much, Yuan. And I just want to take the chance to, thank all the presenters again, Dr. Liu, Dr. Ahmad and Ahmad. Thank you so much. And we look forward to seeing you all again next week. And also a very happy Thanksgiving to all.